That team may include physicians and nurses, community health workers, dietitians, lifestyle professionals, mental health professionals, pharmacists, public health leaders, also spiritual leaders, friends, family, all as a part of our team to manage our wellness as it regards to hypertension. Next slide, please. The other thing that's most important is that we empower ourselves and we empower our patients and the people that we serve, that we are our first advocates when it comes to our blood pressure and our health overall. So it's really important to spread the word that we know our numbers. If we haven't been to see your clinician, it's important that we go. If we don't have access, even stopping into a pharmacy and checking one's blood pressure, being willing to ask questions. When you see your clinician, having a relationship where you're comfortable asking questions and also comfortable changing if you're not getting the answers that you deserve. We are all participants in a shared decision making, but we ourselves, each individual, is the captain of your own healthcare team. Next slide. So let's talk about the definition of normal versus abnormal blood pressure. So normal blood pressure is having a systolic blood pressure, or the top number, being less than 120, and a diastolic blood pressure being less than 80. Elevated is if we are between 120 to 129, and the diastolic is less than 180. Stage 1 hypertension, and these guidelines are different than what they were previously, is really when we have a systolic of 130 to 139, or a diastolic, a bottom number of 80 to 89, just one of those. So for example, if the blood pressure is 125 over 88, that qualifies as stage 1 hypertension. Stage 2 is what many of us knew as the simple old guideline, where if the systolic was 140 or greater, or the diastolic was 90 or greater. So many times, many people who even check on their own might say, oh no, my blood pressure is great. It's 135 over 89, or I only hit 90 sometimes. And that is actually not normal. And these small changes can cause a big effect later on if unseen and untreated. Next slide, please. So as I mentioned before, monitoring one's blood pressure outside of our clinicians' offices is important. It improves diagnostic accuracy. It also helps to unmask white coat syndrome. Some people get very nervous when they go to the doctor, even subconsciously, and we'll see elevated blood pressures, but they'll say, oh, but when I'm at home, it's 110 over 70. So it's important that we check it at home so that we know that it is 110 over 70 and for sure at home, and not the 138 over 96 that we're seeing in the office. Monitoring the blood pressure at home also gives us more data to support medication adjustments properly. And also it encourages patient engagement. And that's important because remember, we're each the captain of our own ship. Next slide, please. Also providing things like patient education, nutrition counseling, lifestyle coaching, and regular follow-up also helps to improve outcomes when it comes to blood pressure. Next slide. So now I'd like to switch gears for a moment and talk briefly about high blood pressure in pregnancy. This is a common and dangerous condition. It is one of the leading causes of maternal morbidity and mortality and requires early identification and close monitoring. Next slide, please. Having high blood pressure in pregnancy can lead to adverse outcomes. Some of those include miscarriage, fetal growth restriction, low birth weight, preterm delivery, placental abruption, where the placenta separates from the uterine wall, also preeclampsia and eclampsia, which we'll go a little bit into shortly. Also cardiac events, stroke, heart attack, maternal and fetal death. And this is of utmost importance, particularly in the tri-state area in New Jersey, where the morbidity and mortality rates are so high, especially amongst women of color. Next slide, please. So let's talk about individuals with high blood pressure who are planning pregnancy. I'll say in another slide, but I'll say it now too. I always really ask patients to please plan prior to pregnancy, especially if you have an underlying condition such as hypertension, because having those levels controlled really makes the difference between good and poor outcomes. So for patients who are planning pregnancy, it's important that they see their clinician prior so that if they're on medication already, their medication can be adjusted to one that is safe in pregnancy, as not all medications are safe. Some examples of medications that tend to be safe are labetalol and nifedipine. Those usually have minimal effect to the fetus. Also, oftentimes, we recommend that a low dose aspirin is started in patients who have high blood pressure during the pregnancy. There are some drugs, as I mentioned, that are contraindicated in pregnancy. And so really having that visit, I usually say at least 3 months prior to planning is important so that the medication can be adjusted. And then we can monitor you to make sure that your blood pressure is controlled. In pregnant individuals, women who have, or birthing people who have blood pressures that are greater than 160 over 110 on repeat, that is severe high blood pressure. Okay. With chronic hypertension, our goal in pregnancy is usually to have the blood pressure less than 140 over 90. We may not be aiming for the blood pressure to be 110 over 70 in those patients, because if their baseline really is in the 130s over 80s, we also don't want to take the blood pressure too low. Next slide, please. So I mentioned earlier preeclampsia, which is obstetrical complication that really increases maternity and fetal morbidity and mortality. So when we talk about preeclampsia, what do we mean? So for preeclampsia, we mean if there is a blood pressure systolic 140 and or a diastolic 90 or greater on 2 occasions at least 4 hours apart in a patient who is greater than 20 weeks pregnant, who normally had previously normal blood pressures, okay? Or if they have a systolic blood pressure 160 or greater, or 100, a diastolic blood pressure of 110 or greater, confirmed over 15 minutes, and if they also have protein in their urine. And we define proteinuria as being greater than 300 milligrams per 24-hour urine collection. And oftentimes when we suspect that someone may have preeclampsia, we send them home with a 24-hour urine collection so that we can calculate the amount of protein that's in the urine. When that's not available, if we have a dipstick reading of 2+, that also counts. And then there's other criteria that not just helps to diagnose preeclampsia, but actually helps us diagnose severe preeclampsia. And that is, for example, when people's platelets are generally less than 100, but also even less than 150. If we see elevated liver enzymes, if we have reduced kidney function, if a patient has pulmonary edema, or what we call toxic symptoms, which may include headaches that don't go away with Tylenol, also pain in the right upper quadrant, visual symptoms, seeing spots, feeling dizzy, feeling out of it, having eyelids that are swollen, to name a few. Next slide, please. So again, it's so important, if you or anyone you know is planning for pregnancy, please plan prior to pregnancy, please, to reduce the risk of morbidity and mortality. We want a healthy mommy and healthy baby, not one or the other, not neither. Next slide, please. So again, these are the newer guidelines that came out on blood pressure for individuals who are pregnant. Again, non-hypertensive counts as a systolic and a diastolic less than 140/90. And hypertension in pregnancy is defined as either a systolic, that is 140 or higher, or a diastolic 90 or higher. It does not have to be both. And I know I'm reiterating that, but I'm doing that because it is so important. So important to improve our outcomes in New Jersey. Severe hypertension is when there is a systolic of 160 or higher, or a diastolic of 110 or higher. Okay. Next slide. So let's talk a moment about prevention and treatment. Next slide. So hypertension in general is often preventable and treatable. And so the 1, 2, 3s per the AHA is adhering to a healthy lifestyle and managing the behaviors of life's essential 8, which we'll go into. Monitoring your blood pressure regularly as part of your routine doctor's visits, but as we mentioned, home monitoring as well. And if you're on any medication, taking that medication regularly and also monitoring your blood pressure so that we know if the medication is working. Next slide. So let's talk about some of life's essential 8s. And Life's Essential 8 outlines the 8 most important factors for cardiovascular health. And there's 4 health behaviors and 4 health factors. This simplifies cardiovascular health so people can better understand it and manage it. Remember, again, we are each the captain of our own wellness ship. Better cardiovascular health has been associated with a decreased risk for heart disease, stroke, cancer, dementia, and other major health problems. Next slide, please. So let's revisit sleep. Next slide. So sleep can affect almost every tissue in our body, right? While we're sleeping, we need sleep to heal and repair ourselves, our tissues, our blood vessels. Sleep's important to strengthen our immune system, to modify our blood pressure, lower our risk of chronic disease, improve our mood, makes us more creative and productive, and also improves alertness, learning, and memory. Next slide. Improving diet. When we talk about diet, I always mention that our food can be our medicine or our poison. And there's often very little in between. So for all of us, letting our medication, particularly as it pertains to high blood pressure, really letting our food be our medication is essential. So an anti-inflammatory type diet that is rich in vegetables, fruits, whole grains, omega-3 fatty acids, in things like salmon and mackerel. Those also help with our blood pressure, as well as things like our mood, our stress. And those, improving those factors inadvertently helps to improve our blood pressure as well. There's actually been some studies on fruits and vegetables that show that eating fruits and vegetables improved mood and happiness. And some people have asked, well, is it that people who are happy are more prone to eat fruits and vegetables? And the way that that particular study was done, it was actually eating the fruits and vegetables improved mood, decreased stress. And if we decrease stress, that has a secondary effect on our blood pressure as well. Next slide, please. So activity, exercise is good for us. It floods our brain with feel-good chemicals and endorphins. It also helps to lower our blood pressure and reduce our risk of heart attack, stroke, and control our blood sugar. And it also can improve our sleep. When we talk about how much we need for exercise, it is important that we're getting at least 150 minutes of moderate exercise in per week, or at least 75 minutes of high intensity exercise per week. And those numbers are true for pregnant women as well, as long as there's no other contraindication as discussed with the pregnant individual's healthcare team. These numbers are also the same in those over 65 years old. Next slide, please. Quitting nicotine. So we know there are several reasons why we should stop smoking if we're smokers. After 1 year of quitting, our risk of heart disease goes down by half. And so that increases our chances of living longer. It improves our sense of smell and taste, which may also help with our food choices as our medicine. And even things like the smoker's cough will go away. Next slide. So let's talk about stress. Simply put, stress can kill. I myself in the office have experienced over the last 2 years at least 3 patients who were on average in their mid-50s, who had had heart events, were told they had heart attacks, and were also told by their cardiologists that the true root cause of their heart attacks were stress. People with high levels of chronic stress or psychological distress are more likely to die of various causes, including heart disease and stroke. It's also linked to anxiety disorders, major depression, and can cause things like irritability, sleep disruption, changes in appetite, gut discomfort, and even reduced fertility. So controlling our stress isn't a luxury. It is a mandatory part of our wellness plan. Next slide, please. And so there are many things that we can do, and these are just a few tips for stress management. Sometimes we can get out of the house and take a walk in nature and enjoy the sights. We can reach out to family and friends. If we have pets, those often provide comfort as well. Having a good sleep hygiene schedule, having a nice environment that's charming for sleep that doesn't include social media and TVs and phones. Also, having a turn off time, meditation, mindfulness, prayer, workouts help as well. And one thing that's not on here are breathing techniques, which things like box breathing and 4-7-8, which I'm happy at the end of this, if we have a moment, to teach all of you at least box breathing, because that's something that can immediately help to alleviate stress, and it's something that you can then pass on and to your family members, the people that you treat as well. Next slide. So when we talk about high blood pressure and cardiac disease in general, it is important that we understand that there are some evidence gaps, and there is definitely more work to be done, particularly in understanding the intersection of blood pressure with race, ethnicity, and the social determinants of health. Identifying alternative and accurate methods to measure our blood pressures, and also BP targets and long-term benefits in younger adults who, as I mentioned earlier, often do not go to the doctor as regularly as they could. So now I think we're going to talk about some of the hypertension initiatives and the local community impact. And so for this part, I am happy to turn it over to Victoria Buhl.
Thank you so much, Dr. Chinn, for that overview. So switching gears just a little bit, I wanted to talk about some of the work that the American Heart Association is doing locally. As I imagine, you're probably all familiar with at least the name of our organization, but not everyone knows really the work that we're doing in our communities on a day-to-day basis. So hopefully you'll learn a little bit and see if there's maybe some ways that we can collaborate in the future. So just really setting the scene and providing an overview of our 2028 impact goal for the whole organization. So we celebrated our 100th birthday last year. And so we're building on that century of trusted leadership in cardiovascular and brain health. And we're trying to drive breakthroughs and implement proven solutions in science, policy, and care for healthier people and communities. And the way that we're doing that in our measurement areas down in that box below is increasing access to care, improving quality of care, addressing health factors, and CPR education. So those are really the main priority areas for the organization as a whole. So some of the community impact and action, and again, I am in northern New Jersey, but I do have a colleague that covers central and southern New Jersey. So this is happening statewide. We're engaging our healthcare and community organizations in addressing chronic disease, especially hypertension. And so that looks a lot of different ways. If we're working with a healthcare organization, specifically our federally qualified healthcare organizations, we are able to provide them with blood pressure cuffs, education, and resources so that there can be a self-measured blood pressure program. And really what that means is that patients are given a blood pressure cuff for at-home monitoring, which, as Dr. Chinn alluded, is critically important in addressing hypertension, unmasking that white coat syndrome and really giving that patient control over their own health and over their own blood pressure measurement. So working with our healthcare organizations and providing them with that equipment and those resources. We are also working with our healthcare organizations in adopting validated blood pressure device listing policies. And I know that's a mouthful, but essentially what that means is that we're working with healthcare organizations to adopt a policy that ensures that any blood pressure devices that they receive, whether they purchase them themselves, we provide them, another organization provides them, they are validated for accuracy by a third party. So that is ensuring that patients are receiving the most accurate measurements, whether that be for in-office measurement or at-home measurements. They are receiving the most accurate, validated measurements on that blood pressure, which is also very important to get, the greatest idea of what their true measurement is. We're also working with healthcare organizations in addressing outpatient quality improvement initiatives. And so it's called Outpace CVD. And there are three kind of branches within that. One that is addressing hypertension called Target BP, one that's addressing type 2 diabetes called Target Type 2 Diabetes, and then the third one for cholesterol, which is called Check Change Control Cholesterol. And so those outpatient quality improvement initiatives are really meant to work with our healthcare partners in helping them improve evidence-based activities that are happening at those offices, and also improving the blood pressure control rates and the type 2 diabetes control rates amongst their patients. And then finally, pivoting a little bit to the community side of things, we are working with our local community organizations, and that could be food pantries, churches, YMCAs, really anywhere, in bringing blood pressure screenings into those communities. And we again provide all of the equipment, all of the resources, education necessary, so that, for example, when someone is at the food pantry, maybe waiting to pick up their groceries, they can measure their blood pressure. And it is really trying to remove a barrier to people having their blood pressure checked if they don't have a cuff at home, or if they're unable to get to a doctor in a timely manner. This is just to really remove a barrier and have people knowing their blood pressure numbers and bringing it into that community space. So those are really some of the ways that we are addressing hypertension and chronic disease in our communities. Obviously we are working with communities that are kind of, I guess, hotspots for hypertension. So in northern New Jersey, Newark is certainly one of our priority communities, Patterson, Dover, Elizabeth, Jersey City, etc. And then the same thing for the central and southern part of the state as well. We're really working with those communities and providing them with as many resources as we can to help address hypertension, because we know how important it is and how pervasive it really is. And then we're also working with new parents in providing them with life-saving education and resources. So trying to provide parents with education around infant CPR, and providing them with blood pressure kits, or I'm sorry, CPR kits, so that they learn how to do infant CPR, that God forbid, if something happens in the home, they know how to respond. And then also providing what we call new mom kits, which includes both a blood pressure cuff for the parent, could be either parent, could be grandparents, whoever it is. I think it's important everyone knows their blood pressure, and then also providing a CPR kit. So again, providing them with that education and resources, because we know that, obviously in pregnancy, blood pressure is important, but also after pregnancy, that is a high risk period for, the parent. So making sure they have access to that as well. And then we're also addressing other factors contributing to hypertension, specifically nutrition security. We know that nutrition plays a huge role in blood pressure. And so we are trying to work with our food pantries in, helping them align with the healthy nutrition standards and adopting a policy, and then also increasing their capacity to store fresh produce. Many food pantries, as much as they would like to be able to provide more fruits and vegetables, they simply do not have the ability to do so, whether they, need more refrigeration, they need a sink to wash it properly. We're able to help them in kind of filling those gaps and providing those resources so that they are then better equipped to provide those things to the community that we know can really make a difference in their blood pressure. And then also implementing nutrition security screenings in both clinical and community settings, and then providing referrals to, SNAP and WIC and emergency food assistance, so that they're able to have food on a regular basis if that is a need. And then the last little thing there is around CPR education and awareness in our communities. CPR is a huge focus for our organization. We are working with community organizations in providing them with funding for AEDs and CPR education, so that they are prepared to respond in the event of a cardiac emergency. And then also, as I said, working with some of our healthcare partners and providing them with CPR kits that they can then distribute to new parents to learn infant CPR. And so that is just a very high level overview of the community impact work that's happening all across New Jersey and really all across the country, but specifically, obviously, in New Jersey. And so just wanted to kind of provide a little bit more insight of what we're really doing on a day-to-day basis in our communities. And so the last little bit we have here is around some copyright and permissions, some acknowledgments for the new blood pressure guidelines that were recently released last year. And then finally, I think we have some time for questions.
Thank you so much, Victoria and Dr. Chin. That was a really comprehensive overview of not only some things that we can consider when doing our own community work, but also some of the community initiatives that American Heart Association is doing as well. If anybody has any questions, they can either come off of mute, or if you would feel more comfortable putting it in the chat, I can read the questions to Dr. Chin and Victoria.
Hi, I have a question. This is Rachel Lendner. I'm in northern New Jersey. And my question is, I know that there were changes in blood pressure guidelines in 2017. And my understanding from what you were saying now is that there were changes again a year ago. And I'm wondering what changed in the guidelines from 2017 until 2024, 2025.
Sure. So I can kind of take that over. And then Dr. Chen, if you have anything to add, please feel free. So the biggest changes I would say is around what is considered a healthy blood pressure or normal blood pressure reading, is that it is now less than 120 over less than 80. Historically, it was kind of seen as 120 over 80 is the gold standard for blood pressure readings, but we're actually, extensive research out of the American Heart Association has seen it should be less than that. And so that was part of the recent guidance that came out in August of 2025. And then additionally, we showed the chart around blood pressure in pregnant individuals. That is the first of its kind chart. Previously, we kind of had suggestions for people that were pregnant on where their blood pressure should be, but we've never had a chart in the same way that we did for, everyone else, I guess you could say. So this chart specifically for pregnant people is new, and that was also part of the guidelines that came out in August of 2025. And Dr. Chen, if you have anything to add, please feel free.
No, exactly that. Particularly with pregnancy, there was always the suggestion, and within the obstetric world, we talked about the or, as opposed to and having this chart that actually came out made it clear for everyone. And like you mentioned, for hypertension in general, that was new from 2017.
Hopefully that helps answer your question, Rachel.
Perfect. Thank you.
Yeah, you're welcome.
Hi, I have a few questions that are in the chat.
Okay.
Caesar Bramon, I hope I'm pronouncing that right, but Caesar is asking, is there a link that we can get more information on these cardiovascular diseases?
Yeah, so I would direct everyone on this call. If you want any more information about the work that we're doing and resources, you can always visit our website. It's heart.org, HEART.org. And you can find tons and tons of resources on our website. Really anything that you might be looking for related to cardiovascular or brain health. And you can also find a lot of our resources translated into Spanish. So if that is a need, and then if there are additional language needs, I'm happy to provide my information and we can get that for you. We are fortunate in that because we are such a big organization and really a global organization, we have a lot of our resources translated into many languages. But first stop, I would say visit our website, heart.org.
Thank you. And then I have another question from Elizabeth Pineros saying, what is the normal blood pressure for an 87-year-old woman?
Dr. Chin, I'll let you take that one.
Well, ideally, we want it still less than 120 over less than 80. Do we give leeway? Oftentimes we do. But we still want that ideal blood pressure. We still want the ideal interventions and with exercise and letting your food be your medicine as well. However, based on any other conditions and based on careful discussion with your clinician, uh, whether or not they treat you at certain points really depends on your overall health.
Thank you. I have another question from Nashawn Bolton, asking how do we go about requesting a representative to speak to our partners, churches, community centers, etc.?
Sure. So this is the plug to fill out the exit survey that Brianna is going to send out, because I am your person. And if it's not in the northern part of the state, I can direct it to my colleague who's in the central and southern part of the state. That is certainly a request that we get, especially in February, with it being Heart Month again. So, you're welcome to reach out to us and, request that person to talk to the community.
Thank you. I have another question from Shireen Naqvi, saying it was mentioned about validated blood pressure devices. However, currently, should electronic blood pressure monitors, for example, Omron or Welch Allen, that many providers use in clinical settings and residents that also use at home, should they be calibrated? If so, can you provide direction as to who we should be reaching out to in terms of a manufacturer or someone else?
Sure. So yeah, those devices should be calibrated, I believe, every 2 years. And generally that would be on the manufacturer. If it is if it is an in-office device, that can be done, at the provider level. But I would say if it is an at-home device, you can either reach out to the manufacturer or perhaps if you have, a provider that you're working with, then they should be able to assist you with the calibration of that as well.
I think there's also a website to validate the blood pressure. I think it might be called, I'll double check, but I think
Validate BP. That's the one that we most commonly use. I don't know if that's the one that you were referring to, Dr. Chin, but yeah, we use validatebp.org. Primarily, there are other websites, but that's the one we primarily use at the American Heart Association. And that has a listing of all of the devices that have been validated for accuracy by a third-party site. And I know some of the Omron ones are on there, and Welch Allen as well. Those are ones that we use pretty frequently, especially when we're talking about some of those self-measured blood pressure programs.
Thank you. Luis Gonzalez is asking, with the new blood pressure guidelines, has there been any changes in suggested medicines and/or dosages?
I'm happy to kind of start that conversation. Dr. Shin, if you have anything to add, please feel free. I would say that it's obviously depends on individuals, on the dosage of medication that they're receiving. Something I will say as well is that, keeping on your schedule for medication is very, very important. Even if you're, feeling okay, I think staying on that medication is very important because as we said, hypertension is a silent killer. There is really no oftentimes evident signs or symptoms to, show that you are hypertensive. So I would say it varies by person as far as the dosage of that medication. But Dr. Chen, if you have anything to add, please chime in.
I agree. I don't think that there were any new guidelines in terms of prescribing a lot. It's a real
Oh,
Did
I
she
think
freeze for everyone else as
yes.
well or just me?
Yeah, she froze for
Oh
me as
no.
well.
Okay. I'm not sure what she was saying. Hopefully she'll unfreeze.
Yeah, I know the question was about with the new blood pressure guidelines, has there been any changes in suggested medicine or dosages?
Yeah, as far as I know, there hasn't been changes to the specific dosage because again, it does depend on the individual person. But there's not, as far as I am aware, there's not been any changes to the specific guidance around the dosage as a result of these changes to the blood pressure guidelines.
Okay, and hopefully when Dr. Chen comes back in, maybe she give a little more insight on
Yeah.
that. But Jean Talley is asking, I go out in the community to do blood pressure screenings. I use your resources, PDF printouts, and thanks. They are very well accepted. Do you have any giveaways or some kits that you can give for community blood pressure screenings?
So yeah, I would, want to speak with you individually to talk about the feasibility of that as far as, providing blood pressure devices or resources, et cetera. If you are in the northern part of the state, I would be your contact person. If not, I can direct you to my colleague who is again in the central and southern part of the state. And we work with organizations, right? So, we're not providing them necessarily to individuals because we are not a direct service organization. But we can work with organizations and helping them secure devices or educational resources, whatever it is that they may need.
Okay. And I see Dr. Chin is back.
I'm back. I don't know what happened.
Yes.
I'm back.
Thank you. I have another question from Sigrid Solis. Who is your colleague in the central part of the state?
Her name is Vicki Cole. She is the Community Impact Director for Central and Southern New Jersey.
Okay. Can that information be provided in the chat, or is that something that I can send out afterward?
If people are interested in learning more, in that exit survey, if you want to just direct those to me and then I can kind of send them out so that, Vicky's not receiving emails that she's not sure of where they're coming from, just so I could give her a little context if that's okay, rather than providing her email address. I'm happy to provide my email address. I could put that in the chat, but yeah, I don't want to necessarily put hers in just in case she's not expecting emails, an influx of emails, but I'll put mine in the chat right now.
Okay. That would be good. Thank you. Okay, I think that's all of the questions that we had in the chat. Does anybody else have any questions that they would like to say off mute? No? I actually had a question. Um, when you talk about the white coat hypertension, that's a very real thing, and it's a thing that I've experienced people in our communities telling me about, and I'm sure other people in the chat have as well. What are some real-time tips and strategies that we can give people in order to deal with that?
So I often I ask patients to monitor their blood pressure for about a week before they come to the office, randomly at different times. I also, depending on how high it is, because sometimes some patients will come in and it's through the roof to where I'm uncomfortable, and I, in some cases, will send them next door to see primary care just to make sure they have follow-up. If patients aren't able, don't have access to a blood pressure machine at home, I ask them to check maybe in the pharmacy, if possible. Or oftentimes patients will have a family member that has one. I also suggest breathing, and I had alluded to that before. Something as simple as box breathing, and I think I had promised if we had a moment to teach it to you just in case. I'll teach box breathing because it's very simple. We'll just use the count of 4. So with box breathing, if in your mind you picture a little box like we see on these screens right now, and you breathe in to your own count of 4, you hold to your count of 4, you breathe out to your count of 4, and you hold it. So I'll demonstrate, and then we can all do one together. You can actually do this even in your car. You can do it at any point in time of the day, and it only takes just a few seconds, but just those few seconds is a game changer with alleviating your stress, and oftentimes as a result your blood pressure. So I'll demonstrate one where I'm gonna so I'm breathing in for 4, I'm holding for 4, and I'm blowing it out for 4, and I'm holding for 4. So I'm going to count for all of you, just so that this is something that you can take with you. I'll be the count for you. So I want you to breathe in 2, 3, 4. Hold. 2, 3, 4. Let it out. 2, 3, 4. Hold. 2, 3, 4. Again, breathe in. 2, 3, 4. Hold. 2, 3, 4. Let it out. 2, 3, 4. Hold. 2, 3, 4. One more time. Breathe in. 2, 3, 4. Hold. 2, 3, 4. And let it out. 2, 3, 4. And hold. 2, 3, 4. And observe how you feel from that. There are many patients who we have them do that and then it goes away. Also, the other tip that I have, I also often ask them to be mindful, maybe even journal. Okay, what does coming to the doctor's office do to you, for you? What experiences may you have had in the past that might influence it? And sometimes they can get to the bottom of it from there. But again, as I mentioned, probably ad nauseum, outside of the office, blood pressure monitoring, home monitoring is key. Yeah.
Thank you. So yes, as you said, monitoring at home and then going to your provider and seeing the difference, telling them what it was at home, and then, comparing it, as well as those breathing exercises, which I think we can all use at different points in time. I think all of those are really key. So thank you for that. I just have one more question from Jintali again about volunteering. I would like to volunteer to be part of your work group or the American Heart Association. Who should I reach out to for that?
You are welcome to reach out to me, and I can direct you to the right person if it's not me. But we
Okay.
always welcome volunteers. That is our lifeblood here at American Heart Association. We rely heavily on our volunteers and we cherish them a lot here.
Thank you. And then I have one more question from Anna
Sure.
Marie Valencia. During blood pressure screenings, if we recommend to a patient to do the respiratory exercise, after how many minutes can we recheck the blood pressure again?
I usually, after they do that, I give them usually about 10 minutes, 10, 15 minutes. And sometimes the difference is remarkable. Mhm. What I do is I do the exercise and I'm OBGYN, so oftentimes patients need to get dressed. I give them a chance to get dressed, open the door, and then now that the visit is completed, then they recheck. So about 10 minutes.
Thank you. Thank you, Anna Maria. That was a good question. Okay, so Dr. Chin and Victoria, thank you so much once again for all of the valuable information. Once again, we did record the presentation. We will be working to post it on the NJ Sophie site. Right now, I'm going to place the form in the chat. Please fill out the form. I'll also be emailing it to all of our participants as well, just to make sure that they get it. But please fill out the form in order to receive the one CHESS or MCHESS credit that's being offered today. And I just would like to thank everybody again for their participation, especially with the questions. They were all really beneficial. And we'll see you next time. Thank you so much.